So patients with COPD are predisposed to developing atrial fibrillation because it's the same mechanism. These patients get a lot of hypoxic vasoconstriction, right, over time just because of the dilation of their alveoli, and because it's been damaged, right, eventually these patients have a lot of pressure inside their pulmonary system, which backs up into the ventricle, backs up into the atrium again, stretches the atrium, and then causes the patients to have a quivering atrium. Second mnemonic is iatrogenic. Iatrogenic is a fancy word for doctors, right? Patients that have heart surgery are also predisposed to developing atrial fibrillation. Let's look at the next one, rheumatic heart disease. Rheumatic heart disease. Well, rheumatic heart disease can cause stenosis of the mitral valve. So these patients can also develop mitral regurgitation. Mitral regurgitation, right? Rheumatic heart disease usually occurs in patients that has a history of a strep throat that wasn't treated, and eventually they develop mitral stenosis. This mitral stenosis will cause this patient's atrium to be dilated. It stretches the wall of the atrium, right? So when I stretch the wall of the atrium, it affects these atrial muscles and causes them to predispose to developing atrial fibrillation. Next mnemonic, atherosclerotics, atherosclerosis. Usually patients that have a lot of plaques inside their coronary system can develop a heart attack, right? So if I have a big plaque inside my coronary arteries, let's say this is the left anterior descending artery, and I occlude it through the thrombosis, and this patient have a MI, which is myocardial infarction. The problem is when you infarct the muscle of the ventricular muscles, when they get infarcted, eventually cause dilation. This patient can be predisposed to congestive heart failure. When you have heart failure, your heart is really, really big, right? You've got a lot of fluids and a lot of blood inside the ventricles, causing pressure on the atrium. And when they try to push against this, right, try to push a fat person out of the way, they get stretched out and they develop atrial fibrillation. MI is the same thing as also known as coronary artery disease, is atherosclerosis. So patients that have atherosclerosis, they have coronary artery disease, which predispose patients to develop myocardial infarction. The next mnemonic is known as thyroid. Thyrotoxicosis, especially patients that have hyperthyroidism. Patients that have hypothyroidism are predisposed to atrial fibrillation. Remember that. That's one of the causes of atrial fibrillation. So you want to, if this is a new onset atrial fibrillation, always check the patient's TSH and free T4, right? Because you want to make sure it's not because of their thyroid problems, all right? Also, the next is known as endocarditis. Endocarditis. When patients have endocarditis, they have infections of the valves of the heart. When you infect the valve of the heart, the bacteria is going to come and take a bite and eat off these valves. Once they eat off the valves, you develop either tricuspid regurgitation or mitral regurgitation. Now, whenever the heart contracts, the blood spills back into the atrium, stretches the wall of the atrium, and eventually predispose patients to develop atrial fibrillation. And last but not the least is sick sinus syndrome. Sick sinus syndrome. So sick sinus syndrome, actually, what happened with sick sinus syndrome is it's actually a syndrome that affects the pathology of the SA node. So for example, when patients actually have sick sinus syndrome, this is what they develop. You look at their EKG and it looks like this. So they fire, you got a P wave, QRS, right? And you got a T wave. And there's a moment of silence. Let's have a moment of silence. A moment of silence, right? And then you got a P wave, QRS complex. Then the T wave, P wave, QRS complex. See that? See this lag in between? That's known as a sick sinus syndrome. There's supposed to be a PQRS complex in here, and sometimes if patients have a lot of atherosclerotic disease that decrease perfusion to the right coronary arteries, this patient can infarct the SA node, and sometimes the SA node might just kind of doze off a little bit, and then wakes up, oh, I'm sorry, I'm supposed to be firing, and then it continues to fire. So it's like a dozing off SA node. That can predispose you to develop atrial fibrillation. So the way I remember, I'm like, so somebody said, the SA node is sleeping. Maybe I could start doing his job for him. Well, don't do that. It predisposes patients to atrial fibrillation, because if you decide to take up his job because you think he's sleeping occasionally, because somebody has sick sinus syndrome, well, the bad news is you're going to predispose the heart to atrial fibrillation. Atrial fibrillation. So now, let's talk about what we got to look for when patients have atrial fibrillation on EKGs. How do we recognize this pathology on an electrocardiogram? Remember, this is a normal sinus rhythm, right? P wave, QRS complex, and a T wave. When patients have atrial fibrillation, there are some important things you need to keep in mind. You want to check the rate at which the heart is firing, the heart rate. You want to see, is it a regular or irregular? You want to see how regular the QRS complexes are. You want to check for the P wave. And also, you want to check the P to QRS ratio. You also want to check the PR interval. And last but not the least, you want to know what the QRS width is. These parameters are the things you got to keep in mind when you look at an EKG that has atrial fibrillation. Now I'm going to go ahead and draw what atrial fibrillation looks like when you look at the EKG. QRS complex, T wave. There we go. Now, I'm going to compare the top to the bottom here so you can see what I'm talking about before we proceed. Okay? A normal EKG, if you look at the P wave, there's a P wave here, there's a P wave here, a P wave here. There's always a P wave before every QRS. P wave before every QRS. P wave before every QRS. You see that? That is normal. So when I look at also the rate, normal heart rate, a normal heart rate should be between 60 and 100. On the electrocardiogram, the way I count it is I look between the one QRS complex, another R, right? R to R interval, and there's different methods by which you can calculate the heart rate of the patient, but typically I look for which of the QRS complex actually falls on the first line and count the next box, which will be 300, then the next box will be 150, next box will be 100, and then the next box will be 75 and 60. So I count 300, 150, 100, and look for where the next QRS falls. If it falls right on 75, in this case, I'm going to say the heart rate is 75 for the patient. Now, when a patient has atrial fibrillation, the heart is quivering. So what happens? We don't get atrial contractions because we're not getting good depolarization. And the P wave stands for what? Atrial depolarization. Since the atrium is not depolarizing, what do we found? Well, there will be no P waves. There will be no P waves. None. So let's look at this rhythm strip that I've drawn out. Let's say this is lead 2. Right? If I look at lead 2, and I'm like, where's the P wave? Is something a little squiggly here? Yeah, that's the squiggly line. Yeah, it's because the atrium is supposed to look like this when it has depolarization. So I don't see any P waves here. I don't see any P waves here. no P waves, no P waves. You might say, oh, what is that squiggly line? No, a P wave should be a nice upward deflection, not a squiggly line, okay? That's just crappy cardia. Now, when I look at, since I don't see any P waves, also, the next thing I want to check is, what is the rate? Okay, the rate in this case actually is very variable. In atrial fibrillation, patient's heart rate is very, very variable. The reason is because their heart rate could be either normal, they can be tachycardic, they could be 110, they could be 105. Okay, so it's very, very variable compared to normal sinus. So the next thing I want to check if I don't see any P wave is it irregular? You want to check if it's regular or irregular. So the problem is, when you look at the regularity, what do we mean by regularity of an EKG? Well, you want to look at the R to R. So I look at this R wave and measure it from here to here. That's equal. That's equal. What that actually translates means the heart depolarizes, right? Atrium contracts, ventricular depolarization, ventricle contracts, blood is spilled back into the body, the ventricle repolarizes, and then the atrium starts to do it again. Which means this is one heartbeat, this is another heartbeat, this is another heartbeat. So my heart is beating like this. See that? It's regular. It's not beating like some funny beat I'm going to make in the next beat, but it's regular, right? You can hear that. So when I look at my R to R, every beat is nice and synchronized, right? Beat 1, beat 2, beat 1, beat 2, right? Beautiful. So when I look at my R to R, it has to be regular. But when you look at atrial fibrillation, you have to eyeball it. Let's look at it. The distance from this R wave to this R wave, it's not the same thing as the distance from this R wave to this R wave. Can you see that? This is a little narrower, this is wider. And just look at this next one. It's even shorter. And then the next one coming along. So the R to R is irregular, irregular. That's the word. So when you hear the word irregular, irregular. All right? So it's not a regular beat. It's all over the place, right? Compared to this nice synchronized heartbeat I'm looking up here. No P waves, irregular, irregular heartbeat. You know that we're talking about atrial fibrillation. Why? Because think about it. The atrium is always trying to depolarize, not depolarizing very well, so the heart is beating funny, the ventricles contract, they're waiting again, and it's kind of very disorganized. Now, the next thing is one is P to QRS complex. Well, the problem is there's supposed to be a P after every QRS. P after every QRS, right? P before every QRS. I apologize. P before every QRS, P before every QRS, P before every QRS, and the T wave. See that? But in this case, if I look at the P to QRS ratio, since there's no P wave, there's none, right? There's no P wave. I can't check the P to QRS ratio when you have atrial fibrillation. What about the PR interval? Well, the PR interval starts from here to here. This is the PR interval. The PR interval is the time it takes for the SA nodes to fire down to the AV node, right? Right there, that's the PR interval. Unfortunately, if I try to look for that, what is the normal PR interval? Normal PR interval is less than 200 milliseconds, all right, or 0.02 seconds. When you look at a rhythm strip with atrial fibrillation, you're not going to be able to determine the PR interval because, number one, there is no P wave. So if there's no P wave, I can't determine the PR interval. So there is none. None. Now, the next thing you want to look for is the QRS width. How wide are these QRS complexes? A QRS complex is usually less than what? 120 milliseconds. 120 milliseconds, which is 3 boxes on the EKG. Box 1, box 2, box 3. 3 boxes. 1, 2, 3. When you look at the QRS width, in atrial fibrillation, it's also going to be less than 120 milliseconds. So it's going to be normal. But why is it normal? It's because it doesn't affect the ventricles. The ventricles are depolarizing and repolarizing. The only problem is upstairs. Think of a two-story building. If people are making noise upstairs and the sound is all restricted to because they're having a problem, if you're not hearing the sound downstairs, it doesn't bother you, right? Exactly. So the ventricles are not bothered. They depolarize, right? They get the message. But the only problem is there's the atrium is where the problem is. That's where the problem is, okay? So, now that you've been able to recognize what causes atrial fibrillation, why people get atrial fibrillation, what the pathophysiology is, and how to recognize it when you see patients developing atrial fibrillation. Remember, this is a very, very, very common disease that we see in the heart. It's one of the most common arrhythmias that you're going to run into. All right? So, just to kind of wrap it up, the way we manage this management of atrial fibrillation starts with A, B, C, D. A, B, C, D. Very simple. A, B, C, D. So, we can either give the patient an anticoagulant, right? Anticoagulation. And what we give for anticoagulation is either a warfarin or known as Coumadin. Usually these patients have to be on warfarin when you give them warfarin. Why do we give patients that have atrial fibrillation warfarin? Is because remember at the beginning of the lecture I told you their heart is quivering, so they have a lot of stasis. They tend to form a lot of blood clots inside the atrium. Well, that's not good because this blood clots can get dislodged, go into the left ventricle, and get pumped out into right into the aorta, and this can go right directly into the brain. And these patients are predisposed to developing strokes. So that is a bad complication, right? So if these patients are not given anticoagulants, these patients can develop strokes. Complications. Well, blood clots can go somewhere else. If they can go to the brain, right, go up to the carotids, they can go down into the belly. And these blood clots can go and block your superior mesenteric vessels, and that can cause mesenteric ischemia. Right? Mesenteric ischemia is basically a heart attack of the belly. You can develop strokes because blood clots can go to the brain, and this can go to the legs to form claudications. So the decreased perfusion to the lower extremity. So that's a serious complications because if these are not untreated, this patient is predisposed to strokes, also myocardial infarctions. Now that we have anticoagulated the patient by giving them warfarin, right, to thin out their blood, you want to control their heart rate because this patient's heart rate can be variable. They can become very tachycardic, right? So you want to give them beta blockers like metoprolol. And what this does is decrease the patient's heart rate, slows the heart rate down so the heart is not beating too fast. You can also give them calcium channel blockers. Right? Like nifedipine, right? You can give them nifedipine, and this is a calcium channel blocker. It's also going to slow down their heart rate. And the last but not the least, you can give them digoxin. Right? Digoxin actually allows their heart to be able to contract more, but digoxin has a parasympathetic effect, which means it activates the vagus nerve, so the vagus nerve can slow down the SA node or the AV node to allow this heart rate to go down in these patients. Okay, that's why you put them on digoxin. Okay, so that's the ABCD of how to treat atrial fibrillation. Remember, if you don't treat these patients, they can get lightheaded because if they're not getting enough cardiac output to their brain, they can syncopize, right? They can get orthostatic hypotension, like get lightheaded because they don't have enough cardiac output. and you want to slow down their heart rate because it can be very unstable because the heart is beating really, really fast, and they get decreased cerebral perfusion, and sometimes they can syncopize, okay? All right, so that's an underlying arrhythmia that can affect patients' life, okay? And that brings us to the end of the lecture on atrial fibrillation. It's Dr. Adesina from ftplecture.com. Thank you. Bye-bye.